Welcome to Health System CIO's interview with Dr. Maulin Shah, CMIO at Providence, and Dr. Staci Wendt, Director of Providence Health Research Accelerator. I'm Anthony Guerra, founder and editor-in-chief. Well, thank you both very much for joining me today. Appreciate it.
Yeah, of course. Thanks for having us.
All right, looking forward to having a fun chat. Understand you've done a study about your use of DAX Copilot. Had some interesting findings, and I think we'll start there. Well, let's start with an overview of your organization and your role. Dr. Shah, you could tell us a little bit about Providence, very big organization, and Dr. Wendt, certainly at Providence Health Research Accelerator would be interesting to hear a little about, and then we'll go from there. So, Dr. Shah?
Yeah, so Providence is a large health system, primarily on the West Coast in Texas. We have 52 hospitals, more than 1,000 clinics. We cover really every specialty you can imagine with our clinical care, as well as having opportunities like the Health Research Accelerator. In my capacity as Chief Medical Information Officer, I am accountable for really driving the adoption of all of our various clinical technology, from our EHR as well as other technologies, and to really making those things at least burdensome as possible, making sure our clinicians throughout our system are feeling as well supported by the technology as possible. What about you, Staci?
So hi, I'm Staci Wendt. I'm the director of the Health Research Accelerator. We're part of the Providence Institute for Clinical Innovation. We're a system level research group where we drive to improve care for patients and providers by piloting innovation and driving systems change at Providence, which, as Dr. Shah mentioned, is the largest community health system on the West Coast. We do this research work through strategic partnerships with life sciences companies and health tech partners. We also partner internally with our system folks like Dr. Shah to answer questions for the systems about how we can improve care and improve the way that our providers are experiencing their work life as well. So part of that research work was a partnership on a study of the Nuance DAX Copilot product. And so this is something that we started several years ago, and we are fortunate to be able to partner in a way that we randomized clinicians to receive the DAX Copilot software either immediately or in a delayed way. And so in that work, before we were using it across the system, we asked clinicians to participate in learning how to use DAX, and then for this group that were randomized to receive it up front, they used it for about 6 months. And then after the study ended, we made DAX available for all of the clinicians who participated in the research. We asked all of the clinicians, those who received DAX and those who were still waiting to receive it, we asked them to participate in a monthly survey where they told us about their experience with burnout, their experience with documentation burden, their connection to their patients, and their frustration with the documentation process. And so we followed these changes over time for each of the clinicians in the study. And then we also looked at some objective measures of documentation burden, which we captured through our Epic system, through metadata, looking at the time spent in notes after appointments and the time in pajama time, which is time that folks spend outside of their workday. And we followed those metrics also across the course of the study. And then we also looked at, for the folks who were using DAX, the proportion of the appointments that they were using DAX over time. And so from those results, what we found was that both from the objective measure, so looking at the time that the clinicians spent in their notes per day, we found about a 2.5 hour a week drop or difference in the pajama time for our clinicians who were using DAX compared to our clinicians who were not using DAX. And we also saw that the clinician reported experience of burnout and frustration with documentation process also was significantly lower for those who were using DAX compared to those who were not using DAX, and for those before they were using DAX compared to after they were using DAX. So these results, both the longitudinal nature and the randomization, which is like one of the first studies to use randomization for DAX, really strengthen our findings here that there is something going on in terms of the way that this technology can help reduce burnout, help clinicians focus on the reason why they got into medicine, which is to help patients and to serve patients, listen to patients, and not be overly focused on the documentation aspects.
All right, very good. Lots to go into there. Dr. Shah, you got a million things going on in the health system, right? A lot of rollouts, a lot of technologies, all kinds of stuff. It's almost, and you tell me, this is how I'm thinking of it. You tell me if I'm wrong. You have Dr. Wendt and her crew as this unit that can help evaluate what's working and what's not by doing these studies, which are probably pretty intense, and they're a big deal. They're not just little things. So you have to decide based on everything we have going on, where do I want to put the microscope? Where do I want help from this group to, like, I want to examine these three things for certain reasons, because you can't have Dr. Wendt look at everything. Right? Am I on the right track here that you pick certain spots and put the microscope on it, and that's what she's done? Now we take those learnings and try and extrapolate them and make the rollouts even better.
Yeah, I mean, you're spot on. That's a fantastic, that's one of my favorite questions I think I've gotten. That's a fantastic question. We have a million things going on. Whether that's trying to improve the quality of care, reduce burden, whether that's really making sure the patients have the best experience with our technology, like there's a lot going on. I think what we have to do is we really have to focus in on those interventions where it's not really clear the best way to do it or what the outcome will be. And it's both, right? Like, so there are some interventions that are probably clearly valuable, but if we don't apply them in a evidence-based way, we're not going to get the value. Adoption is everything. I was laughing with a friend yesterday talking about having a Ferrari in the garage is not really helpful, right? And so we have these amazing tools like DAX. If they're sitting in the garage, they're not helpful. So one is really partnering with the Health Research Accelerator to help us not only understand the impact, but what are the variables, what are the factors that are going to help us drive adoption and really get the most value. Within that space, though, we still have to decide, right? We still have to decide what is it we're going to look at. And that's where I think it's important to look at, you only have so many resources. What are the things that Providence brings to the research community that maybe other people don't? For example, an academic research center is going to do something very different than what a community center can do. And I think some of the biggest things we offer are community care at scale. So what are these things that can scale, that can actually impact broad numbers of people and have an impact across all of our domains? And how we actually make that happen? It's one thing to implement something at 3 hospitals and 10 clinics. It's very different when you're trying to do something really, really big. If you look at our medical group, I think it's the first or second largest medical group in the country when you peel it out of where Providence is. So, I mean, these are large systems that we can really have a scalable impact. The problem is that when you're at scale, it's not like because I have 50 hospital, I get 50 times the resources that a single hospital gets, right? So I've got to find the ways to make it scalable without necessarily scaling resources in a linear fashion. So those are all questions that I can ask the Health Research Accelerator to help us, like, what are the most scalable projects? As we're partnering, the other thing we look at is what are the kinds of projects that are likely to fit into that space but have been unresearched. So DAX was great, but our DAX study was from a few years ago, and we were doing ambient before it was cool. And so that was definitely a landmark thing for us to really know we needed internally to double down on ambient well before I think the industry was moving there. We have other technology we're building in-house, other technology that we are certainly partnering to build, partnering and bringing in from third parties that are all kind of in that same realm of, do we yet know if this is a scalable technology? Is this a scalable bit of machine learning and predictive analytics? Is this a scalable implementation of in-basket, patient message improvement? I think those are the kinds of things that we end up studying.
All right, very good. Dr. Wendt, one of the things I'm wondering, you do a study like this, you're trying to figure out, is this tool being used and is it useful by those who are using it? And a lot of whys in there based on, what you're finding. Why this, why that? I mean, you could have a situation where the technology at a certain level, and this is what you're trying to find out. The technology at a certain level could be useful, but perhaps just the particular tool we're using isn't the right tool. And if we don't look for that subtlety, we just assume that this technology isn't working when it's really the tool, or it's some other way that we rolled it out, or there's some other nuance in why it's not going as well as we thought. How do you do these studies to find those nuances and really tease out so that you don't take the wrong conclusions? And I know that's your specialty, is designing these things so that we get real knowledge out of it, useful knowledge. So your thoughts there?
Yeah, we don't always get the opportunity to conduct a research study alongside something that we're doing at the organization, because we don't have unlimited resources. So we do have to be very thoughtful in the type of research and when we get the opportunity, how we're conducting the research or what type of data we collect. And so I think one of the spaces where we try to be in is that we don't just look at one source of information. And so we try to use our quantitative data. We try to use objective measures. We try to talk directly to the users of the technology to understand what their barriers to use are. We don't just stop at usage data. We're also interested in understanding, like, what visits might this be the most helpful in? What are there certain is there a certain level of documentation burden that clinicians experience that makes them someone who's really likely to benefit from this type of technology? And so I think what we're looking for is triangulation across multiple data sources that indicate to us that either something's working or something's not working. That is just as important of a research finding as finding that something works, so that we can really hone in on what's effective and continue to do more of the things that are working, and tweak or understand why things are not working. So I think with this first DAX study that we conducted a couple of years ago now, we tried to pull in those objective measures of documentation burden, the clinician reported measures. We also have an additional study happening right now where we're really taking even more of an in-depth mixed methods approach, looking at talking in-depth interviews with our clinicians about kind of the nuances in their use of the tool and when they think it might be the most helpful versus not, and how that kind of interplays with other tools that are available to them.
All right, very good.
I'll just add real quick.
Yeah.
I mean, I think one of the great things working with Staci's team is they help us find confounders, positive or negative. So for example, we have this one tool that is for triaging patient messages, helps us make sure we address the most effective one first, and ultimately reduces the turnaround time for sending out messages, responding to messages. That's all well and good, but we saw in certain clinics, it didn't do anything. In others, it did a lot. You start looking at that, like, what's happening here? You're like, oh, well, this one had 6 medical assistants leave the practice in the last 8 weeks. Like, there's nothing you can do about that. So rather than it being like a pure observational study where like before and after, they can really help us like hone in scientifically to understand the broader picture than just the one little thing that we might be testing.
So, Dr. Shah, I mean, and Dr. Wen, I'll let you go too on this. What would be the main takeaways here for improving satisfaction and use of this tool based on your study? Do you have sort of a list of 2, 3 main things that, when we are seeing challenges or a lack of uptake, here are the things we want to fix going forward or adjust either on our end or things we'd like to see the vendor adjust?
Staci, I'll let you go from a research perspective, and then I'll take it over from our current learnings of in vivo.
Yeah. So I think when we conducted this study back a couple of years ago, we identified clinicians who were experiencing a heavy documentation burden. And so the impacts that we see in this study are probably more relative to those clinicians who do have this heavy burden. And so that might be one space where they're, with all tools, not just with DAX, there might be a ceiling level effect of if someone isn't having any documentation burden or their workload is manageable, they might not benefit from all the tools. It's finding like the right tool for the right clinician or the right kind of need there. And so I think that's one of the spaces coming out of the original study was just that we did really focus on those who were experiencing a lot of documentation burden. We saw a really big shift in their documentation burden. That to me indicates that this would be a great tool for those folks. We did hear feedback, and it's changed since, technology is changing and improving at a rapid rate. So from 2 years ago, the onboarding to use DAX has significantly changed. And I think that was one of the spaces that we heard anecdotal feedback from our research participants, was that some of the training early on with DAX was intensive. And we certainly saw that where it would take a little bit of time for folks to be using it on a strongly regular basis. And that is something that has been solved in the last 2 years. The onboarding for the
so you're saying the training
technology is a lot less.
When you talk about the onboarding,
training portions,
the training. So you said the training, we had to improve the training, which we've done, and there's been an effect from that. So that's important. I want to help people out there who are trying to use these tools better. Obviously, training is going to be a big issue, and it sounds like you're saying we upped the training game, and that's had an effect.
Well, I will caveat it that I think what we heard several years ago was that the training was intensive, but since then the technology has improved so much that I think the training is basically none. Or you don't need as much training now because the technology has improved so much. But I'll let Dr. Shah talk about that.
Dr. Shah, yeah, go ahead, please. Yeah, we've learned a lot, and the technology has changed. I think we went through this period of like, this is a huge lift to get on board, but then you'll love it. We moved to the, you know what, you could do this in a few minutes, read a little one pager and you'll know how to do it. And actually, I think we're finding a sweet spot between the two now, where it's clear that we had a set of early adopters or even kind of early mid-stage adopters who just picked up this technology once it kind of became mature and just have run with it. But we've also hit a little bit of a slowdown, right? We're a little asymptotic with that. And we want to continue to grow across our entire medical group. What we're finding is the best ways to do that aren't the simple, like, I mean, this isn't an iPhone from 2006. Pick it up and use it and you know what to do, right? I mean, that's, I think, what the vendors would have you believe. But the fact is that you're going to do better if you're a power user, if you really know the ins and outs of it. And so what we found is like one-on-one coaching with our physicians over time, they can already be using the tool, helps them to really become sticky. We do have a drop off. There's a certain number of people who use the tool and then drop off from it. Those are a group that we're really trying to understand, because is it that we picked the wrong people? Did we not serve them enough in terms of education? What exactly was going on? Or are the feature set just not enough yet? We do know also that our vendors are starting to add more and more what I would call sticky features that are going to be real satisfiers and are going to really continue to drive down that documentation burden. But all of those features are going to come with a cost of complexity, circa iPhone 2025, right? Like you will pick up an iPhone these days and it's a pretty complicated device. You've been doing it for 20 years, so it's okay. Kind of what's happening here is they're adding all sorts of amazing features that are completely necessary. But I think it's going to actually ramp up the need to support these physicians to be able to get the most benefit out of these tools. So lots of excitement, but I think it's not plug and play. It's not like pick it up and you're just going to be an awesome expert. Some people will, but you know, if you think of the bell curve, the 1/3 or so of people who are early adopters are going to do great. The bottom third who are just having a hard time with technology may or may not benefit from it, depending on how they're kind of feeling about the tool. And I can talk more about that later. And then the middle third are the ones that we really need to support, because I think we can get them over to getting the most benefit out of it. But it's not free.
Dr. Shah, who are the people in your organization that do the training? So who's like the group or the army of people that you talk to about the training for these tools? You know, the discussions you have where you discuss one-on-one support for certain users, and all users are not the same. You know, there's groups that require and deserve more attention because of their value to the organization, let's be honest. And there are other people that you're going to have a more of an automated approach that scales a little better. So who's that universe of people? And from all my conversations, that universe of people is becoming more and more and more important. I guess they're the informaticists, but maybe there's another word for them. Go ahead, please.
That's informaticists. I mean, that's what we call them. So I lead the team of clinical informaticists at Providence. We're about 500 strong. We're accountable for all of training, support, adoption, and what we call success. And success in our vernacular is making sure a clinician is operating as effectively with all the tools around as they can. They're successful at using the tools around them. So we're accountable for all of that. In that, we have a one-on-one coaching program. We have, seminars, we have small groups, we have all sorts of different ways to engage different kinds of clinicians where they're at. We are then super closely aligned with our operational partners. So in our case, the medical group, we're very closely aligned. And so together we come up with strategies to how to find the right physicians to interact with, whether we interact with local medical directors or send out lists or get lists. We have a way to create essentially a heat map to figure out exactly where we need to spend the resources to get the best return. We also partner with our vendor, with Microsoft, who is able to give us usage data, right? Be able to get us information about our users, who's using it, who's not using it, who dropped off. We're able to take that as well. So we put all of that together into kind of a package of kind of 360 support to really drive the utilization of DAX and ambient in general.
Do you see, again, you're sort of over these 500 informaticists. Do you see IT, do you see yourself as being, in a sense, part of IT? Or do you see IT as another unit that you interact with just the same way you interact with Dr. Wendt's group?
No. I'm 100% part of IT.
Part of IT.
Our information services, as we call it. We are the clinicians. Most of my staff has some kind of a clinical degree or a clinical informatics degree. I'm a physician. All my direct reports are nurses and physicians. So we are the clinicians embedded in information services, making sure IS is really attentive to the needs of our frontline caregivers. Like, we are there to make sure that things are going well, and then turning around to the clinicians and making sure they're using the IT well.
So you're in IT, but you described IS as being something different.
Oh, no, that's just what we call it.
Okay.
So
all right.
Information services.
So you are IT,
information services, yeah.
But the CIO infrastructure network, they're going to be more technical, and you're there to, bridge that gap to the operational side. It's just interesting to
I
me.
think that's a fair thing. So, I mean, not to get too far in the weeds, we have a CIO.
Yeah.
My org, clinical informatics and strategy, kind of comes up into the CIO. Our CTO, which includes like cybersecurity and infrastructure and cloud and all that kind of stuff, comes into the CIO. Our applications come into the CIO. So that's Epic and the other clinical applications. There's more. I'm not trying to leave anyone out, but like, that's the general premise. So I'm a peer to our applications. I'm a peer to our CTO. Like, we're peer organizations that all have to work together to drive the best outcomes.
Yeah, and so again, it's about use. It's as more and more people are saying, forget about just turning things on. It's important, keeping the lights on. Stuff has to run. Stuff has to work. But it's about use. That's how we're defining it. And how are your clinical colleagues feeling about these things? Well, let's go back to the fact that you mentioned people dropping off. That's of concern to you. Anytime you have, because your life is use, right? Your life, your work life is based on use, and you had them, and you lost them, and that's frustrating. Why do we lose them? Do we get one-on-one conversations with those people to understand what's going on?
100%. We definitely are like doing interviews, especially that's where we again partner with Staci's group, where we'll do interviews. We'll we'll also interview around them, because maybe their perception is a little different than the perception of their clinic and that kind of thing. But we're still learning. I don't have it like, oh, this is when people drop off. We know that sometimes it's not enough features. Sometimes people's work is so templated that they don't need DAX. Like, it's so simple. Ear infections are what I see bread and butter. I don't need DAX for that. Sometimes it's deemed as like, this is not the quality I need for my own note. So people that are very attentive to their very specific words and how they want it to read, and they're just very attentive to the note, may or may not like it. So there's a lot of different kind of categories. Some of them we can address, and some are like, well, that's probably a good thing you're not using it. And then some are, well, can we move you along the spectrum? Like, do the specific words matter as much as you think they do? These are compliant. They are, they're understood. It's not like you're reducing understanding. This is really your style. Are you willing to spend all this time for your style, or do you want to get home on time? Like, those are the kinds of conversations we have to have.
All right, very good. Help me understand a little bit more about the dynamics between Dr. Shah, your main entity, and then Dr. Wendt's entity in terms of deciding what to study. Is it Dr. Wendt, do you sort of are the decisions made on your end based on a whole lot of requests, and you've got some sort of governance over there that helps, just like an IT department would have a limited number of resources and only be able to tackle a certain amount of projects at one time. There's a governance process to figure out what they're going to work on. Do you have the same kind of thing on your side, where we've got a lot of requests to study all different kinds of things, and here are the things we've decided to study based on our overall mandate?
Yeah, we do have a lot of requests. I mean, the size of our health system, we're always testing new things. So we do have a lot of requests, too many for us to do every single one. But I think we make the decision about what to focus on in collaboration with folks like Maulin. We also think about our strategic priorities for the organization and how we can help answer some of the questions for the overall organization, which is ultimately focused on improving patient care. And so that's kind of how we make those decisions. And we have some projects that are kind of a shorter turnaround. We try to do multiples of those in a year. We have other projects like the DAX portfolio of studies that we're doing over the course of many years. And I think that one of the really wonderful things about this partnership with Maulin as well is that in some cases we don't have the resources to study something right now as it's rolling out, but what we have done through this partnership is implement some basic foundational research infrastructure that can help as Maulin's team is rolling out new technology, just by including some randomization aspects, allow us to kind of retrospectively look back and see what the impact is. And we're able to also help create templates and dashboards to help answer questions that maybe don't require as much in-depth research from the team. So I think it's kind of a varied approach depending on the question.
Now,
go ahead, Dr. Shah.
Yeah, no, I'll add that my primary outcome, as you said, is use and not research studies, right? So what's super helpful here between us is bringing research rigor for me to understand how to drive our internal operational objectives. Now, if that then comes to fruition as a paper, great. But being able to bring that science, like that research rigor, and not just be, well, I think it's going okay. Well, we have more users today. That must be good. And instead really be able to say, like, here's the metrics. Here's how we can build dashboards that we can trust are actually reflecting what we're trying to do. That's the partnership that I really appreciate. And we, even in clinical informatics, all of IS, we can only work on those things that are strategic priorities for the organization. Nobody's got free cycles anywhere in healthcare, including at Providence. And so we are always looking at how are we driving our overall strategy set from our CEO on down with the work that we're doing. And that's how we kind of make those decisions.
So are you saying that you've learned a lot from Dr. Wendt's group based on the studies they do and how they do them, that when they're not available to work on something that you want to look at, you take those techniques and you do it yourself, so to speak?
Not quite what I'm saying. What I'm saying is that when we want to have that research rigor to our data, because we're not sure if just observational data is okay, we reach out to Staci's team.
Right.
He may or may not have resources to create a whole research paradigm around it with a plan for a study, but they can come in and consult and be like, hey,
okay,
here's how you might randomize, here's how you might do this thing. They can't build the dashboard all the time.
Got it.
Helping us understand how to do our work helps us do it better.
Got it. So Dr. Wendt, you're like, listen, I can't do the full boat on this one, but we could come in and take a look. We could do a light treatment, something like that.
Yeah.
Yeah, and I think, I mean, Maulin's team is totally capable. I think one of the space that we've really found a nice partnership is like in strategizing about what those confounders might be. And taking those into an account so that Maulin's team can build out a dashboard that they're looking at usage, and we can help say like, hey, this might be something that's impacting that. And so I think we do those consults all the time. It doesn't always, like Dr. Shah said, always have to be a full-blown research study. I think generally trying to roll things out in a like learning health system type of way where we're focusing on the things that are working is beneficial to everyone.
Well, Dr. Wendt, let's get a little more into that. And what we want to try and do here is for organizations that are smaller, health systems that are much smaller, don't have someone in your position, don't have an entity like that. What's your best advice for those organizations, and speak to the IT executives like Dr. Maulin at those organizations? I guess a DIY, a do-it-yourself type thing, or maybe not that bad, but something. How can they evaluate use of different technologies with an eye towards improving training, rollouts, and that kind of thing? How do they do it when they don't have such a rigorous entity that can help them?
Yeah, that's a good question. I mean, I think that not every tool will be able to be rolled out in this way, but I think if teams are thinking about a new technology that they are going to try out to offer to folks, thinking about any way that you can introduce some sort of randomization into that rollout. And so it doesn't have to be that there's one group that just never receives it. Any sort of like staged, or we would call it a stepwise design, where you're giving it to one group and then you have a time period that it happens to another group and you're looking longitudinally across that. I think that is I'm not going to say the easiest, because it's not always easy to do that. So there are cases where you can't do that. But if you know that something is going to be rolled out for an entire organization and you're able to think through kind of this stepwise design, it might also help in the rollout because you're not focused on doing it completely at scale. You can kind of practice or pilot with one clinic or with one clinician. And I think anytime you can introduce that kind of randomized design will benefit in terms of the finding and in terms of drawing some conclusions about what might have been helpful for that specific tool.
I think that's brilliant advice. Go ahead, Dr. Shah.
Yeah, zooming out from that, I've been doing this a long time and like coming on my 20th year. We never used to measure anything ever, right? Like and I would argue that the vast majority of places don't. They take a enhancement, they take a new thing, they're like, looks good. If the vendor happens to provide metrics, they'll say like, hey, it looks good, which I don't think there's a lot of vendors are going to tell you it doesn't look good.
Right.
So having the rigor to anything you're doing to say, what is the thing I'm measuring? What's the thing that I am making better with what I am doing? And what am I worried about? So both what's the positive and what's the potential negative, so I can watch both of them. Just doing that took like the first 15 years of my career. It was really so if I could just get that done, now being able to add in some of the cool stuff from research and randomization and structured surveys and that kind of stuff is amazing. But just like you're rolling out DAX, like measure more than users, because that's what your vendor is going to say. It's like, we have users. Like measure satisfaction, measure time and documentation, measure something. There's ways to do that in your EHR. But if you don't measure it, you can't monitor it, you can't improve it.
Yeah. Do you think there could potentially be a disconnect there if you don't intentionally focus on it between measuring and improving? You can measure something and say, oh, here's the results. Oh, okay. Now what do we do with that? How do we make it better? Does one always flow from the other? If you're looking at the right things, meaning measure and fix, or can those be disconnected and somehow you sort of miss the end goal?
I would argue that most often not directly related. Measuring is a monitoring tool. How are we doing? It doesn't necessarily say this is why we're doing as well as we're doing. Different questions to be clear. Measuring the other one is actually way harder, right? Like, what are all the little pieces I need to measure to get to my overall. And are those the right ones? Way harder. But in a smaller system, let's say 100 docs, like you can then do some rapid experimentation. You can see that documentation time is not going down for some reason, or in surgery, it's not going down. Let's go talk to the surgeons. Let's figure that out.
Yeah.
I can't do that. I have to talk to surgeons at 50 hospitals. It doesn't happen. I can't do it like systematically. And so it's a little different. Sorry about the noise. He came back in.
That's okay. That's okay. Just roll with it. We have a guest, special guest. We're just gonna go. It's Dr. Maulin's son is visiting. It's okay. Go ahead. So measuring. Yeah, that's my question. And a follow-up on that is I've been talked to a lot of people who's talking about different pilots and things like that. There's some nuance in here where you can run a pilot and you can intend to measure certain things, and you can either realize that you measured the wrong thing, or what you measured didn't really give you the information you wanted, or you were measuring the right thing, but you didn't get the right metric and you sort of missed it. One way or the other, you kind of missed it. You have to decide at that point, do we need to extend the pilot to try and capture the thing we wanted to capture, or are we done? We already spent our money. We gave this a shot. Dr. Wendt, maybe if you want to comment on that, it's sort of just missing the mark. I mean, this is what you do for a living, is making sure you don't miss the mark. But not everybody's as specialized in this as you are, and they can miss the mark. And that I guess they can be really frustrating.
Yeah, I mean, hindsight is 2020. So I'll share, like, I've gotten to the end of a research project before and been like, why didn't we measure that one thing that's so clear to us now that was important, but wasn't when we started this. And I think, I think the way to kind of like what Dr. Shah said is like sitting down and thinking about like, what are we expecting to see the change? What would be the positive? What would be the negative? Like, if you can just take that time before rolling something out to really, I mean, in the research world, we would call it a logic model, thinking through like, we're going to implement this thing and what are we expecting it to fix, or what are we expecting it to address? And I think a team-based approach, like, our research work, we never operate just by ourselves. We would be measuring the wrong things. Like we need to partner with these teams and understand kind of what their insights are and what their hopes are. And so I think that's another space, is just getting that gathering perspective and including a team that's multidisciplinary in planning that research, or just asking for some feedback. Like, hey, these are the things that we're thinking of measuring. This is the data that we have, and then moving forward from there. But I feel like at the beginning of planning for something, gathering that feedback early will really pay dividends in terms of what the research project looks like moving forward, and the possibility of not getting to the end and saying like, oh, if only we'd asked that one question of folks.
Right.
In the end, this is a business, and you got to make calls based on perfect data. You got to understand the priorities of the business. You get as much data as you can, and you make a call. That's just fundamentally what you have to do. You can't wait for perfect data in the day-to-day world. Neither can Staci. So we just, you go with what you got, and you use your brains and your gut and your team to figure out the next step.
There's always going to be a better research study next, like coming out of even the study that we had, there was questions that were like, oh, this would have been great to know. But at the time, we just needed to do, this is what we could do. So I think, don't let perfection get in the way of.
That's a great expression, right? Don't let perfect be the enemy of good, or however people want to put it. I think what you mentioned, Dr. Wendt, about and Dr. Shah, you touched on this a little bit before. So there's this issue of rolling things out, the idea of the pilot, and rolling things out slowly and iteratively, which I like. It's always what I wish I could do. If I'm doing something new, a new program that we're offering, or something like that, I would love to do one and then get the learnings from that and then do another one. It's more difficult when you have to do multiple at the same time, because it's hard to accumulate the learnings each time. Things are happening so fast. That would be similar to rolling things out in multiple hospitals, like a tool for the first time. You'd much rather roll it out in one and then learn everything you can, then roll it out in another, because it keep getting better and better. But sometimes you don't have the luxury right, of doing that, because there's a speed element here. The doctors want a tool, for example. They're all talking about AI. They want to know why are they using it across town or in the other state. So there's a speed element here, but rolling things out in sort of an optimal way sounds to me like it would be something that would be done slower. So there's a conflict there. There's a tension there. I'd like to hear from both of you. Dr. Shah?
Yeah, most of what we do is all at the same time. And there's a lot
Yeah.
of reasons for that. This is what we call Big Bang. We may be able to do a small like study pilot, and then we got to learn and go.
Okay.
There's a lot of good reasons for that. I mean, I think one is there's diminishing returns on subsequent pilots in terms of what you're really going to learn. Like you can learn like a lot from the first one, maybe a little from the second one, and then you just kind of know what you need to know. So there's that. Second, I think that the longer I'm piloting, the longer I am supporting multiple disparate workflows.
Okay.
And I can't do that. I can't at scale support like somebody's on version 1 and somebody's on version 2 and someone's on version
Yeah.
3. And like, oh, but version 3 is going to interact with the other tool this way. So I got to know how, oh, they can't use this computer. I can't. I got to have standardization. I got to have like clear set of tools. So we go big bang almost always with almost everything as long as we can. And we might be able to do some piloting or studying upfront. I mean, what we're able to study is probably 20% or less of our overall work. I mean, we gotta move, and we have a lot of work to do.
But Dr. Wendt, what about this iterative, approach you mentioned and rolling it out in a different way here and a different way there? It sounds like that's going to give Dr. Shah fits at night if we did that at a big scale.
Yeah, well, conducting research in a real world setting is different than conducting research in a lab. So I think that's like what applied research looks like. I think that's what drives me into this role, is that I like thinking about what happens in the real world setting. And yeah, we're not going to tie a research project to every single thing. That would be impossible to do. But I think the ways that we can help are identifying the spaces where we do have a really big question, or it's going to be a big impact for the organization. That would be maybe something that we would pick to try to put some research design around. And then we also can learn from the previous research studies. So we can learn from the DAC studies about like the pieces of the tool that were useful, and Maulin's team can look like, it's not rocket science necessarily to understand that folks are experiencing a lot of documentation burden.
Yeah.
Burnout is real. So tools that can help alleviate that and get clinicians back to doing what brings them joy, like Maulin's team should be doing that work ahead of how the research team can keep up with it. But I think we have other spaces where we collaborate and can continue to build that research base. And we also don't, generalizability. I'll just add this one last thing for research. Yeah. Generalizability is important. And so health systems don't have to continue to do research studies when there's already work out there that is on populations or with clinicians that are generalizable to their own system. So I would say to other healthcare systems, and us included, folks can look to the studies like on DACs, for example, and say like, hey, these were clinicians, they experienced similar things that are going on in our system. DACs might be a good tool for us. And so I think that's where the sharing and building the scientific base for these tools can really help.
All right, let me just ask you one final question. I'm gonna let you both go. It has been a wonderful chat. Let's look forward. Dr. Wendt, I'm going to start with you. What's maybe one of the studies you're working on right now that may be interesting that, for our audience, that's just something you're looking at?
Oh, wow. I did not expect that question.
It just came to mind.
It's a great one. I think one of the things that we've been looking at is a pretty comprehensive look at atrial fibrillation across our patient population, and the ways that, so we've done a very large retrospective cohort analysis of our patient care across atrial fibrillation. We've also done a very in-depth look with our clinicians and providers across the AFib care continuum. And a lot of that, the findings from that work is something that's informed our System Heart Institute in terms of their strategic priorities for 2026. And so I'm excited to see some of our findings from that research work get incorporated into the tools and the care that our Providence caregivers are providing and our patients will experience in the coming year.
Would you think of that? I mean, to me, that's super clinical as opposed to what we're discussing today, what we discussed today, which is a pretty the use of an application and a tool like that. But the one you're talking about sounds very clinical. Is that right?
Yeah, and this is a change in kind of in the way that that clinicians are kind of talking with patients about patient care, and the way that Providence as an organization is engaging with patients around care for their atrial fibrillation diagnosis.
All right.
So a little bit different, but that's the one that was top of my mind today.
No, that's great. That's very cool. Very cool. Dr. Shah, wow, so much going on with AI. You know, the ambient notes is a very popular one, but things are moving cutting edge, agentic AI, bots, deployments. What's sort of on your radar is sort of something you're looking at working on?
So I'd argue that the first thing we're working on is understanding how to evaluate AI. And whether that's partnering with Staci's team or internally or partnering with external groups, how do we make sure an AI that is brought into our system is safe, responsible, reliable? Like that's min-spec. We have to be able to do that. And that's still a burgeoning area of research, of understanding. That's the very first thing we have to do, because people are coming at us in every direction with this AI that, oh, let me summarize your note. Let me automatically code for you. Let me talk to your patient. Let me take your history. Like, it's mind-boggling. So for us to come up with a rubric to understand risk, as well as understand like how we're going to look at these models, is number 1, 2, and 3 on our list. We are looking at sort of, we classify our AI into the same categories that we classify any other software and any other work we're doing. So how is it applying to our strategic vision, our strategic plan? Right now, part of our strategic plan is making Providence the best place to give and receive care. Well, best place to give care, it means reducing administrative burden, letting clinicians work on the things they want to work, talking to patients. And so that's where DAX comes in. We have multiple other things in the pipeline, again, both commercially and internally developed, to kind of work on that space. So some areas that are super interesting to think about are in the acute setting. We've talked about the clinic all day today. What happens in the hospital? What is creating burden in the hospital? What is new that's creating burden that we can address? And frankly, one of the biggest things in that space is texting one another. You can now text to your doc and to the nurse and to everybody through your EHR, and it creates this cacophony of messages, and you're trying to sit here, take care of your patients, whether you're a nurse or a doctor or anyone else. How do we sift through that? We believe AI could be used there. In Basket, we've talked about before, and you've seen in many of our other kind of documentation around really trying to reduce the burden of thousands and thousands and thousands of patient messages coming to a physician who had literally no time kept aside to work on that. How do they take care of patients over email effectively and be safe about doing that when they haven't been given any time to do that? Well, we think AI can help there. So we look at these targeted areas where we know there's specific problems tied to our strategic plan. So what can we bring in, whether it's from a vendor or internally developed, or from our existing vendor like Epic, to really help those plans. We're trying to be as precise as we can because there's just too much coming at us. And if we're not precise, we're just going to get lost.
Absolutely, 100%. That's brilliant. That's a great point for us to wrap at. I could talk to you all day, but I know you both have probably other things to do. But that was wonderful. Dr. Shah, Dr. Wendt, I want to thank you so much for your time today, and I hope I can catch up with you again down the road. I really appreciate it.
Thank you for the opportunity.
Have a great day.